Sir, unmute.
Very good afternoon to everyone present here. With warm greetings, it gives me a great pleasure to extend a warm welcome on behalf of the surgery department for this webinar on thyroid malignancy. Our Dean, Dr. Prognosis for this webinar, and I also welcome our Vice Principal, Dr. Usha Madam, for this webinar on thyroid malignancies. I also extend my warm welcome to today's speaker, Dr. Shanmugam sir, Surgical Oncologist from Mission Karakal, for accepting our invitation and for this today's seminar. I also welcome our AMCH faculties and students for this webinar. Now I request our HOD to introduce the speaker.
Good afternoon, sir. First of all, I'd like to extend my thanks for accepting the webinar consideration. And this topic you have chosen, this is a very important topic for the undergraduates who are going to appear for the examination, and common topic and common cases which we have come across in the OPD. So we'd like to hear from you. So I'd like to introduce the speaker, Dr. Shanmugam, who did UG and PG in Panther Medical College and MCH Surgical Oncology in JIPMER. And now he is working as an assistant professor in Department of General Surgery, Karakal, Mission Medical College. I would like to extend my thanks for accepting. We are waiting to hear from you, sir. I would like to ask our Dean to say a few words about this webinar.
Good afternoon to one and all. Respected Vice Principal, Dr. Shah, Medical Student, Dr. Mohan, Professor and HOD of General Surgery, Dr. Vinyana Samadam, and Professor Navneetan, and the other department people in surgery. I congratulate them for organizing this a very important topic, CA thyroid, and its latest management. Hope this will be a very useful to all the, not only the students, it's for the practicing doctors. I think you will throw some light on the recent advances in the management of advanced malignancy thyroid. This I congratulate the Department of General Surgery for organizing such a wonderful workshop. I'll welcome all the delegates. I thank the speaker for accepting our invitation and come over for this webinar. Thank you very much for giving an opportunity. Wish you all the best.
Thank you.
Sir, over to you, sir, for the topic.
Yes, sir. Sir, good afternoon to all, sir, all our eminent senior professors and students, and thank for the opportunity. Since I am a growing surgeon, this is a very great pleasure for me to talk about the thyroid cancer, because all the panel members are surgeons. I'm happy about that, and very thankful for the opportunities. And thyroid cancer, we know that it is a common in our country. And how I designed my presentation is, I'm not going to deal with the very rare things. what is the common thing? If any patient comes with a thyroid swelling, what is our approach? If it diagnosed as a malignancy, what are the pitfalls in diagnosis and what are all the controversies and how we are concluding in the treatment options? So as of So all of us know the thyroid cancer, which is the commonest endocrine tumor. Commonest endocrine tumor is the thyroid cancer, and commonly it will affect the females. And the most common age groups will be after 30 years, and it contributes the 1.5% of all cancers. And this is the epidemiological part. And the risk factor, as all of us we know, the radiation is the commonest and established risk factor for the thyroid cancers. And some thyroid cancers will be associated with some familial syndromes, familial adenomatosis polyposis coli, Gardner syndrome, Corney syndrome. And the most important aspect will be your medullary thyroid carcinoma, because it has the familial predisposition. So any patient, if you're if you're diagnosed a medullary thyroid carcinoma, the family history and their family member should be examined. That is the point number one. Point number two from the slide is the radiation exposure. Initially, 15 to 20 years back, they treated the lymphoma with the radiation, acne with the radiations. So any history of radiation, even it was given 15 to 20 years back, it is important. This is the two important risk factor and established risk factors. All others are just a contributing factor. There is no level one evidence to say that these risk factors are there to produce the cancers, like iodine intake, goiter size, and different variants. So the take-home message from this slide is, if it is the medullary thyroid carcinoma, if you come across any patient with the medullary thyroid carcinoma, we should examine the other cancers and other familial predisposition. One, and any history of irradiation with the thyroid swelling, we have to suspect malignancies. And you know, the next you come to the clinical examination. So before going to the clinical thing, you have to understand the tumor biology. So one organ, this is thyroid carcinoma, it produces different type of cancers, whether it is a differentiated or it from the parafollicular C cells, or it from the lymphoma or other variants. So before that, so we know how the tumor biology defines the clinical manifestation. As of we know, the tumor can spread through lymphatics or blood and local spread. So the local spread symptoms will be common for all types of thyroid carcinomas. If it aggressive, if it grows, it can infiltrate the recurrent laryngeal nerve, the voice change will be there. If it infiltrates the trachea, dyspnea will be there. If infiltrate the esophagus, patient may develop the dysphagia. But if what is the most important thing other than this is, if it is a papillary thyroid carcinoma, it commonly spread through the lymphatics. So you have to examine the lymph nodes, or any patient presenting with the lymph nodes, you have to suspect one is the papillary thyroid carcinoma. Other variants which can produce the lymph node mets commonly are Hertel variant and medullary thyroid carcinoma. So by just doing the clinical examination, we can diagnose what it may be. So the important point is, if what is the mode of the spread. So papillary thyroid carcinoma is commonly spreading to the lymph node. So any patient with lymph node mets with the thyroid swelling, you have to suspect a papillary thyroid carcinoma. But the point to be remembered is, medullary thyroid carcinoma and Hertel variant can also present to the lymph node mets. If you take the hematogenous spread, it commonly by the follicular carcinomas. So all of us may come across, at least we have seen one patient in our life, they may present with the pulsatile swelling in the scalp or other parts of the body. We will think that it is a scalp tumor, other things, and if you do the FNAC, it will be a follicular carcinoma. So the point is, if it is a hematogenous spread and it is a pulsatile spread, it will be a follicular carcinoma. So the follicular carcinoma, the blood spread is more common. In that, medullary thyroid carcinoma also can spread to the blood. So it can produce the bone mets and the solid organ mets. So from this slide, what the point I want to convey is, before doing the clinical examination or the organ which we are examining, we should know the at least some tumor biologies. So if it is associated with the lymph node, or whether it is associated with the bone spread, or it is associated with the organ mets. So the point is, papillary lymph node mets are common with the papillary thyroid carcinoma. Herthal and medullary also can produce the lymph node mets. And bone mets, solid organ mets are more common with the follicular carcinoma. In that, medullary thyroid carcinoma also can present with the both the things. And as of all of us know, anaplastic carcinoma, it will commonly be a locally aggressive tumor. This is from the clinical examination point. So then we are after examining, we have to do the investigations. In that, we have to do the systematic manner. So if all of us know, thyroid will produce a endocrine organ. So before touching the thyroid, we should know whether the thyroid is euthyroid or hyperthyroid or hypothyroid. Concerned to the malignancy, hyperthyroidism and hypothyroidisms are very rare. Most of the malignant tumors, 99% of the malignant tumors are euthyroid status. So before doing that, just by doing TSH, we can confirm that it is in the euthyroid status. This is the point number one. Second thing, before going to after the clinical examination, if your features are suggestive of malignancy, other things, we want to confirm that by doing the ultrasound. So invasive tests are later. So first we do the ultrasound. So commonly, what is the ultrasound features are? You have if you are having some lesions, by doing the ultrasound, we can know whether it is solid or cystic, which lobe is involved, what is the spread in the, whether it has the multicentric or multifocal tumors, and whether it has the invasion to the surrounding vessels, and whether lymph node spread is there or not. This much information we get it from the ultrasound. The point in the ultrasound is, what are all the features which are suggestive of malignancies. So any tumor, any ultrasound findings, if they are telling the lesion is solid and it associated with the irregular margins and it associated with the increased central vascularity with the microcalcifications, these features are more suggestive of malignancy. These lesions to be considered as malignant unless proved otherwise. And we have to proceed from that. And the another thing, they will tell the tumor should be taller than the wider. That feature is also risk factor. That means the tumor will spread by centrifugally. So the anteroposterior diameter will be more than the transverse diameter. So the solid pattern, increased vascularity, irregular margins, microcalcification, taller than wider. These 5 features is there in any ultrasound finding. We have to take it cautiously and we have to evaluate. This is the first test. So first we are doing whether it is, what is the thyroid function status. We are confirming that it is in the euthyroid. Then we are doing the ultrasound. It will clinch the diagnosis nearly almost all the patients. Nowadays, the Rayleigh B-mode ultrasound, they are able to give the diagnosis. Then we are proceeding with the FNAC. So FNAC, we know that most of the time the pathologist will have the give the diagnosis. But before that, any invasive investigation, it has some limitations, because most of the time in the periphery, the surgeon will take the FNAC and they will send it to the other places to examine the slides. So that time, if the slide is adequate, if slide is satisfactory only, the pathologist can interpret and can give the results. So first question is, what is the satisfactory specimen? To say it is a satisfactory specimen, it should contain at least 6 clusters of follicular cells, and each cluster should contain at least 10 follicular cells. So to say it is a satisfactory FNAC slide, it should contain 6 clusters of follicular cells and each cluster should contain minimum 10 cells. If it is there, it is called a satisfactory specimen. Then only they can give the report. So the reporting system will be commonly followed will be a Bethesda system. So they will tell it is unsatisfactory. If the satisfactory criteria is not filled, they will tell it is unsatisfactory. Otherwise, they will tell it is a benign. And other 3 things, they will give it is a atypia of undetermined significance or follicular lesions of undetermined significance. This is one variant. Other thing they will tell commonly which we encounter, follicular lesion, follicular neoplasm or Herthal neoplasm they will give. Third thing will be suspicious of malignancies. And the last one will be malignant. If they give malignant, we know how to proceed. But the problem will arise this indeterminate lesions. The indeterminate lesion means ATP of undetermined significance or follicular lesions of undetermined significance, or they are giving only a follicular neoplasm or suspicious of malignancy. So this will arise the problem how to proceed from here. Whether we will take this lesion as a malignant, or we will proceed for total thyroidectomy or surgery, or we will take it this sense, we can wait or watch how to proceed from that. So the question is how to proceed for the indeterminate lesions, the undetermined ATP of undetermined significance, follicular lesions, suspicious of malignancy. In that, it not by doing a single test, we will not arise to some conclusions. So the thing is, so what is our clinical finding and what is our ultrasound finding, and what the reason thing what they are doing is the molecular analysis. So they will have the gene expression classification. So nowadays, the tumors, all tumors will be a personalized treatment. That means they will have a specific mutations. If you take the papillary, they will have the PAX8, PAP-AR mutation, red BTZ rearrangements, or PRAP mutations. They will see in that even the cytology, they can analyze the molecular details and they can categorize the lesion. This is high risk, this is the low risk, like that. So the answer for the how to proceed for the indeterminate lesion is more important, because we will daily practice, we will come across this type of reports. So how to proceed is, what is the cytomorphological features, what the pathologist is feeling, and what is as a surgeon we are feeling, and what is the sonologist is finding. If you want to conclude all these things, do the molecular testing. The problem is it's not readily available in Tamil Nadu, but the answer for this question will be a molecular typing. That is the recent evidence. And the thing is, this is about the indeterminate lesion. The second thing is the new classification by the World Health Organization is the borderline thyroid tumor. Like that, what it means, what is the way I put the slide is, sometimes the pathologist will see the slides, but they will not come to some conclusion whether it is a benign or malignant, other things. So these borderline thyroid tumors are equivalent to carcinoma in situ. These are equivalent to carcinoma in situ. They are considered as the uncertain malignant potential. They will have the follicular-like features. They will have like a follicular adenoma or carcinoma, but they can't tell it is malignance. So this will be 3 categories will be there in the borderline thyroid tumors. So follicular tumor of uncertain malignant potential, or well differentiated tumor with the uncertain malignant potential, and the non-invasive follicular neoplasm with the papillary nuclear features. In that means they will have the papillary thyroid carcinoma like nuclear features in that follicle also there, but they can't tell 100% that it is malignancy. So this is the new problem or a new categories in the FNAC, that is uncertain malignant potential. So these are all the things about the FNAC. So we should know what is satisfactory specimen, what is the Bethesda types, how to react for the indeterminate lesions, what is this borderline thyroid tumors. These are all the some highlighted things in the FNAC. So once we diagnose this is discussed. And FNAC, as we know, it is a minimally invasive, pure risk. Its false positive is low, false negative also is acceptable. And the only problem, the commonly asked UG questions, the FNAC will not differentiate the follicular adenoma from the carcinoma, Hurtl adenoma from the Hurtl carcinoma, because it will be diagnosed only by tissues by the capsular and vascular invasions. This is for the UGs, but FNAC, all other types, it will, most of the time, it will diagnosis. If you take the papillary thyroid carcinoma, they will have the papillary structures. The most important thing will be your nuclear features are more important in the papillary thyroid carcinoma. So they will have the all orphan-any nuclei, clear nuclei, the pushed nucleolus to the side. So it will appear like a cartoon character, orphan-any. and they will have the nuclear grooves and the intranuclear cytoplasmic inclusions. So to diagnose FNAC, the papillary thyroid carcinoma features, nuclear features are more important. In that, the nuclear groove is the diagnostic. So other thing will be intranuclear cytoplasmic inclusions and orphan nuclei. If you take the Hurtl neoplasms, they will have the more abundant mitochondria. So eosinophilic cytoplasm with the granularity. If you take the medullary thyroid carcinoma, they will have the amyloid stroma. So there will be some clinching points will be there to diagnose in the malignancies. So from the point, so we know what is the ultrasound features. We know what are the points in the FNAC, how to diagnose, and classification system. All of us know from the follicular cells, if the tumor arises, it will be a differentiated thyroid cancers. It will be commonly papillary or follicular or Hurtl variant. If it arises from the parafollicular C cells neuroendocrine things, it will be a medullary thyroid carcinoma. If it is a dedifferentiated, it is an anaplastic carcinoma. From the lymphoid tissue, it will be a lymphoma. Or secondaries from the other site can arise to the thyroid. So here the point which I want to stress it. So if the patient having a thyroid swelling, but we are not encountering all the classical features. If you are suspecting metastasis, so then the question arises, how to differentiate the primary thyroid carcinoma from the metastatic. In that, we should know the importance of immunohistochemistry. So thyroid will have the expression of thyroglobulin and thyroid transcription factor 1. If these two factors are there, mostly we will conclude that it arises from the thyroid. If these two factors are not there, mostly it will consider as a metastatics. The point is how to differentiate the primary from the metastatic would be immunohistochemistry, the role of thyroid transcription factor and the thyroglobulin. So this is about the classification systems. So we small few points about the each type of cancers. These things everybody will know. The papillary is the most common tumor. The human will be commonly affected, and most common radiation induced tumor. The prognosis will be related to the size. In that, the point which I want to stress is thyroid paradox. So what is thyroid paradox? So we know that all tumors will be solid, but sometimes thyroid, it can present as a cystic. The primary may be solid, but secondaries may appear as a cystic. So this is a contrary to the expectation. So they will tell it is a thyroid paradox. And this is already discussed. So histologically, they will have the concentric laminar calcifications, this is samoma bodies, but it is not must for the diagnosis of the papillary thyroid cancer. That is the point. So the point, the most important, the clinching for the papillary thyroid carcinoma will be your nuclear features, not the samoma bodies. So the nuclear groove, intranuclear cytoplasmic inclusions, these are all the important things rather than our samoma bodies. So samoma bodies will be there. And we know it is a multicentric and multifocal tumor. Commonly, it will spread to the lymph nodes. And if you take the follicular variant, mostly it will be encapsulated tumor, commonly occur in the older people, and it will be a more aggressive. It spread through the blood vascular invasions. Hematogenous spread will be there, and commonly the lung and bone. So in that, what is the difference between the thyroid carcinoma metastasis and other carcinoma metastasis in the bone is, even metastatic sites are functional, they are hypervascular, sometimes it will be a pulsatile. So that is the point. If it is having the bone metastasis, how to differentiate the bone metastasis from thyroid from other cancer would be, the thyroid metastatic cancers, particularly follicular variant, will be even the metastatic sites are functional. That means they will take the iodine 131, and that is the principle for the iodine treatment. So they are functional. And second thing, they are hypervascular, so it may be a pulsatile. So the point is, when you're before putting the needle, even any bone metastatic lesion, particularly the scalp lesion, just look into the thyroid, because it will be vascular. If you put the multiple pores, we may have the hematoma. That is the point in the follicular. And Hurtl neoplasms, as it is a initially it's considered as a variant of follicular lesions. Now they categorized it is a separate tumor, it arises from the follicular cells. So it has the features of follicular, but the cell, it has the different names, oncocytic tumors, arthal neoplasms, things. So what is oncocytic or Ashkenazi cell means? The cell is a large oval cells and it has the aberrations or mutations in the mitochondrial DNA. That is the point. It has the mutations in the mitochondrial DNA. So the mitochondria will be abundant in the cells. So it will produce a eosinophilic things and it will be clumped. So it will produce the granular appearance. So if you are seeing that eosinophilic cytoplasms and the granularity, it is if you are seeing the Hurtl cells and it occupying more than 75% of the tumor, then it named as a Hurtl cell neoplasm, because the Hurtl cell can occur in the Graves' disease, Hashimoto's thyroiditis. So just mere presence of Hurtl cell alone is not the diagnostic of Hurtl cell neoplasms. So the point is, it has the aberration in the mitochondrial DNA. So there will be accumulation of mitochondria. So it will produce the eosinophilic cytoplasm, and the clumping of mitochondria will produce the granularity. So eosinophilic cytoplasm with the granularity, and the cell is present more than 75% of the tumor, occupying more than 75% of the tumor, then it labeled as a Hurtl neoplasms. And the point number one. Second point, this how it differs from the differentiated thyroid cancer is only 10% of the tumors are iodine 131 avid. That means 90% of the tumors will not take up the radioactive iodine. That is the point. So usually they will divide into adenoma, Hurtl adenoma and Hurtl carcinoma. In that carcinoma, they will divide into minimally invasive or widely invasive. So the point in Hurtl neoplasm is the typical oncocytic or Ashkenazi cells, why it is eosinophilic and granularity, and how many percentage of cells should be there, and it is less than 10% only iodine 131 avid diseases. This is about the Hurtl cell neoplasms point. So medullary thyroid carcinoma, only few points, and just I am running the slides because we know that it is a, as I initially told you, it is a familial predisposition will be there. So most of the tumor will be sporadic, but 2 out of 10 patients will have the familial predisposition. So any thyroid patient, thyroid lesion, and you are seeing FNAC report medullary thyroid carcinoma, you have to think about the syndromes, and you have to think about the familial predisposition, and we have to examine the family members. This is the point which is more important in the medullary thyroid carcinoma, because why the syndromes are more important means they will have the association of pheochromocytomas, meant 2A, 2B, in both things pheochromocytoma will be there. So without evaluating the pheochromocytoma, we are just merely posting the patient, we are just killing the patient. It's equivalent to we are killing the patient. So if the medullary thyroid, if you are seeing the report of medullary thyroid carcinoma, 2 things should arise. One thing, see for the familial predisposition. Second thing, see for the associated syndromic things. So we know that it is a red proto-oncogene mutations, and it is autosomal dominant. So autosomal dominant, so male and female are equally affected, and the tumor markers commonly used are calcitonin and carcinoembryonic antigen. These 2 tumor markers are commonly used. And FNAC, by seeing the amyloid stroma or by doing the immunohistochemistry calcitonin positivity, we can diagnose the medullary thyroid carcinoma. And the medullary thyroid carcinoma, usually it will spread to the bone and the lung. So these cases, we should evaluate that part, particularly if the calcitonin is more than 50 or 100, we have to do for the metastatic outcome. And we know that 80% of the tumors are sporadic, usually unilateral. How to the difference between sporadic and familial things. So sporadic things will be unilateral and not associated with other endocrinopathies. Peak onset will be 40 to 60 years, and females are most predominant. Because of the increased VIP and serotonins, they may have present with the diarrheas. So syndrome, simple one, they will have the medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidisms. And when 2B, medullary thyroid carcinoma, pheochromocytoma, and other neuromas or morphonoid habitus will be there. So why this important is, in the medullary thyroid carcinoma, this gene mutation should be analyzed. And in oncology, there is some cancers, there is a role for prophylactic surgeries to prevent the prophylactic surgery. As all of us we know, BRCA mutation is positive, we are doing the prophylactic mastectomy, which is reducing the risk of breast cancer by 99%. Like that, if you take the thyroid, this medullary thyroid carcinoma has that role. If their mutation, they will see the particular gene number. If that number is there and that is mutated, even the child of that mother should get operated. So the men 2A is less aggressive, men 2B is highly aggressive. So men 2B, less than a year if possible, we have to do the total thyroidectomy. That is the point. So the simple thing in the medullary is, first thing, it's a red proton gene mutation. The most important point is, first is the familial genetic predisposition, and the family members should be examined. That is the point number one. Point number two, associated endocrinopathy should be evaluated. And before proceeding for the surgeries, we have to look for the other things, hyperparathyroidism, pheochromocytomas. And if the family members are diagnosed, their siblings also should be screened for that red oncogene. If it is there, and prophylactic thyroidectomy is recommended. So the anaplastic, as all of us know, it will occur in an older group, and this is the tumor where the males are slightly common than the female, and mostly it will be undifferentiated tumor, and it can following the radiation. As all of us know, it will present as a locally aggressive, so large, diffuse, very hot, rapidly growing, in a highly recurrent, and it will infiltrate the surrounding structures. So lymph node mets also common. So anaplastic thing would be, it will be undifferentiated. The point to carry home message is, it will be a locally aggressive tumor. It is an undifferentiated tumor, and it will occur in a older group, male also equivalent to females, and it will be locally aggressive. So this is about the few important points about the each tumors. So if you come into the staging, so we covered the investigation part, then we covered the pathological part. Now the staging system. So any tumor, any cancer in oncology, it should be staged clinically, because we can communicate as a universal acceptable communication. So the commonly, the various classification systems are there. AMCH, games, systems, other things, but commonly followed system will be your TNM staging. So commonly we are following now the 8th edition, we are following AJCC. So in that tumor size, according to the tumor size and the tumor spread, they will divide less than 2 centimeter, 2 to 4 centimeter, more than 4 centimeter minimal thyroid extension, and the maximum thyroid extension. So the point to be noted in the staging systems. So what is the important, or how the staging system changed, how it applicable to clinically is, initially the age is the important criteria in the thyroid cancer. So initially they consider as 45 age is the risk factor. Now the 8th edition, they are giving us a 55 is the age group. Second thing, so tumor with lymph nodal spread can be cured by surgery and our adjuvant treatment. So if you take the age, 7th edition, they told stage 1 and stage 2, the difference should be the tumor size. But 8th edition, they are giving the importance to the lymph node. So whether lymph node is positive or negative, they upgrade the staging. Third thing, even the thyroid is minimally, it going only infiltrating, it comes out of the capsule and touching the strap muscles, minimal thyroidal extension. Initially it was staged in the stage 3. Now we know that our advances in surgery, we are able to resect and reconstruct esophagus, trachea, other things. Even the extrathyroidal extension, which are resectable and reconstructable things, they will put it as any tumor, they will put it as a T4A. So any tumor, even the oral cancer, other things, T4A means they are locally advanced, but still cure is possible. So if you take the thyroid, it infiltrating the strap muscles, recurrent laryngeal nerve, trachea, even the esophagus, still we will consider these tumors are curable. So they upgraded T4A tumor into stage 3. And inoperable tumor, if the thyroid tumor is infiltrating the pretracheal fascia, it infiltrating in completely and helping the carotid vessels, then they will put it as a T4B. and metastatic diseases. So the staging system, what is the carry home message is the age, the other tumors, other solid organs or endocrines, age will not be included in the staging systems. But in thyroid cancer, age is included in the staging system, point number one. Point number two, even the nodal metastasis and locally advanced tumors are not considered as a stage 4 tumors. That is not a incurable tumors. These are all able to resect these tumors. So the lymph node status and locally advanced things will be under stage 2 and stage 3, not stage 4. And all of us will know all anaplastic carcinomas will be considered stage 4 because of her aggressiveness. So if you come to this is about the staging system we are doing. So the point will arise for any tumor. If you take the breast, we usually used to do the ultrasound, CT or MRI or PET CT. The point is to assess the staging, whether CT or PET CT is needed for the thyroid, because nowadays everybody is writing, we are having so many centers. So the PET CT is a routine for all cancers. So the point, before going to the prognosis, I want to stress one point. So for considering the thyroid malignancies, we should know the differentiated thyroid cancer. The principle is it is a TSH dependent tumor. We are going to treat with the iodine 131. So if you do any contrast, we know that any contrast CT, we know that it will contain the iodine. So this iodine will produce the stunning effect in the further treatment of the thyroid neoplasms. So we should not do the investigation unnecessarily for any thyroid malignancy patients. So the indications for CT in a thyroid malignancy is, if you have any doubt about the resectability, if I am anticipating the laryngeal resection, I am anticipating the carotid invasion, I am anticipating the esophageal resection, then only your CT is needed. For routine mobile tumors, easily operable tumors, there is no role for a routine CT scan in the thyroid cancer. Point number one. The next question comes. See, all the tumors we are doing the metastatic workup. We want to know whether the tumor has spread to the bone or lung, other site. Is it applicable to differentiated thyroid cancer? No, because even in the differentiated thyroid cancer with the lung metastasis, still our next treatment will be iodine 131 treatment. For that, we need the complete removal of the thyroid. Then only your iodine 131 will go and reach the metastasis. So your metastasis is there or not, most of the time it will not interfere with your management unless it is asymptomatic. So the point is, there is no routine role for your CT scan, and the PET scan, absolutely no. There is only one indication for the PET scan in the thyroid cancer. If the tumor is recurrent tumor and the tumor is not iodine 131 avid, it is not taking or not, the lesion is, the thing is, the patient having the recurrent tumor, my thyroglobulin is elevated. I am doing the iodine 131 scan, it not picking up the lesion. That means it is a iodine 131 resistant or non-avid disease. That time, the ideology is the tumor is going to differentiation to de-differentiated tumor. That time, the PET will be useful to know whether the disease is there or not. Other than that, there is no routine role for the PET scan. This is about the point about the staging systems. So if you come to the prognosis, again, there will be a different things, the grade, age, metastasis, what is the size of the tumor, extent of the tumor. They will have the games, they will divide into masses, other system, but these things are not routinely followed. So what if we have come to the treatment? So simple things. So I'm taking only the differentiated thyroid carcinomas. So all of us will know. So differentiated thyroid carcinoma, it is a TSH dependent tumor. So if I have to do surgeries, the principles of oncological surgery will be, you have to remove the primary and where it can metastasis. So I have to remove the occult lesions. So in thyroid, we have doubt. What type of surgery to be performed? Whether to do lobectomy or hemithyroidectomy or a near total or total. That is the point number one. And which patient we should do the nodal dissection as a routine thing. These two answers to be two questions to be answered. So the point is, why we are doing so usually what we are following will be, if any tumor which is more than 0.5 centimeter, most of the time we used to follow the total thyroidectomy. So the rationale why we are doing the total thyroidectomy in a differentiated thyroid cancer patients. We know that the tumor is multicentric, multifocal, rich intrathyroidal lymphatics, and it can spread to the other part of the thyroid. So that is the point number one, why I have to do the total thyroidectomy. And the most important thing will be, we are using any, if you take any tumor, if you take ovary, we are using CA125. If you take colon, we are using CEA as a follow prognostic marker or to detect the recurrence. In that aspect, we are using the thyroglobulin, because thyroglobulin will be secreted only by the thyroid gland, not by any other tissues. So thyroglobulin is present in the body means the patient having thyroid in the body. So to use the thyroglobulin as a marker and to use the iodine 131 effectively, we need the total thyroidectomy. And to decrease the recurrences, because if it recur, if you are doing hemithyroidectomy, if it recur, it will be difficult to go and operate, to avoid the surgical complications and to improve the survival. So the points why I am doing the total thyroidectomy means, one is, the important point would be the thyroglobulin, to use the thyroglobulin as the tumor marker, to use the iodine 131 effectively as adjuvant treatment, to avoid the multicentricity, multifocality and rich intrathyroidal lymphatics, and differentiated thyroid carcinoma 1 to 2%, it can change into anaplastic carcinoma. To avoid that and redo surgeries, there is a high risk for parathyroid and recurrent linear. To avoid that, and it will improve the survival. So this is the reasons why we are doing the total thyroidectomy. So the problem, as a inexperienced surgeon or a new into the field, there is a possibility of injuring the recurrent laryngeal nerve and the parathyroid. So at least even the experienced persons, the temporary hypoparathyroidism will be common. Is there any role for the lobectomy? The counter points why I will do only lobectomy. These are all the points. They will tell the multicentricity, multifocality are only theories. It will not into the implications, and we can avoid the major surgeries so that we can avoid the hypoparathyroidisms and recurrent laryngeal nerve. But these points are not valid. It's level 1 evidence to say that we have to do total thyroidectomy if the tumor is more than 0.5 centimeter. So if the patient comes somewhere, the hemithyroidectomy was done and it was diagnosed as a malignancy, whether to complete the thyroid, other things, yes, it's better to complete the thyroidectomy, particularly the aggressive variants, multifocal disease. If you are doing the ultrasound on the other lobe, if it has the disease or positive margins, they have not done the nodal dissections, or extrathyroidal extension is there, or plus resections, in these variants, it will be better to do the completion thyroidectomies. So come to the node, we know that thyroid commonly it will spread to the central compartment, level 6 pretracheal and pharyngeal nodes. From that, it will go to the lateral nodes. So whether we have to do the node dissection for all the patients or prophylactically, or we have any indication for elective node dissections. So the point is, when the tumor is T3 or T4A tumor, minimal thyroidal extension or more than 4 centimeter tumor, or it infiltrating the strap muscles, esophagus, other things. So T3, T4 tumor, by imaging, by ultrasound or clinically, it is an indication to do the central compartment neck dissections. So central compartment, we know from the hyoid to innominate vessels and recurrent laryngeal nerve by sides. So from there, we have to remove it. The only problem will be a high chance for the hypoparathyroidisms. So the thing is, central compartment neck dissection prophylactically not needed for all the patients. For all the thyroid patients, you no need to go and do the central compartment neck dissection. So whom it is needed is pathologic T3 and T4 tumor. Yes, it is advised central compartment neck dissection. Whom you do the lateral compartment neck dissection is if the patient is having a right side thyroid cancer and the central compartment is positive, then better do the lateral compartment on the tumor side. So that is the point. Otherwise, a patient is presenting clinically with the level 2 or level 3 nodes, just complete the neck on that side. So the point in this neck dissection is If the patient having, there is no role for the prophylactic neck dissection for all the patients. Point number one. Patient is having T3, T4 tumor, prophylactic central compartment neck dissection is needed. Lateral compartment neck dissection is done in a patient whom they presented with the lateral neck nodes, or their central compartment on that side is positive. So this is the point we should know about the central compartment neck dissections. And the most important other thing will be, after doing the total thyroidectomy and the neck dissection, we will have our pathology report with us. So nowadays, what we are oncologists, other people are following will be a American Thyroid Association risk stratification system. In that, they will divide into low, intermediate, high risk, because it is to decide the adjuvant treatment. That means radioactive iodine 131 treatment, and the suppressive L-troxin, to decide the suppressive L-troxin level. So how they will divide will be, if it is a intrathyroidal tumor and we did a very good surgery, it is a R0 resection, it will consider as a low risk. But if you are doing a high risk variant in the papillary, they will have another 15 type of variants: tall cell, columnar, diffuse sclerosing, hobnail, insular, like that. If the highly aggressive variants are there, or vascular invasions are there, if node is positive, they will consider as a intermediate risk. Or any R plus resection, you are leaving the tumor and coming out, or a gross extrathyroidal extension or metastatic disease, it will be considered as a high risk. So the point is, why we have to stratify this risk stratification would be, after the pathology report comes, we have to stratify into these three categories: low risk, intermediate, high risk. Low risk patients, they will not need any other further treatment. Suppressive L-troxin is fine. But intermediate and high risk, we need the radioiodine active adjuvant treatment with the iodine 131 treatment. That is the point. So if you are having the things after the surgical things, that is what I told, I summarized. So we have to do the follow, no cross residual disease. You have to do the TSH and the thyroglobulin measurement. So before measuring the thyroglobulin, anti-thyroglobulin antibodies should be ruled out. So low risk patient, we are doing a good surgery. If it coming under ATA low risk category, then we are putting them on L-troxin. Then we are doing the regular thyroglobulin follow. If thyroglobulin is elevated, then our recurrent lesions, it will consider as a biochemical recurrence or structural recurrence. We will act accordingly. If you are leaving the gross residual disease, so most of the time what will happen, they will do the thyroidectomy, but neck nodal will be left. So in that cases, first you have to remove the all gross diseases. So in that you remove the neck dissection. Then you categorize the risk. They will come under immediately intermediate or high risk. Then go for the treatment. So irresectable metastasis, other things, then you consider for the iodine 131 treatment. So if you come to the iodine 131 treatment, we know about these few points. So in that, first thing will be, we know that it is a iodine 131 avid diseases. So your TSH should be more, so only your iodine 131 will be taken up by the residual lesion or metastatic lesion easily. So for that, we need the thyroid hormone withdrawal. So how long to discontinue? Usually after the surgery, after doing the total thyroidectomy with neck dissection, we will not supplement immediately with the L-troxin. We will leave it for 3 weeks. We make the TSH more than 30. Then we will go for the iodine 131 scan. If the patient is in severe, the patient is not tolerating the hypothyroidism, any heart patient or failure patients, if they are not tolerating the hypothyroidism, then you can supplement with the T3 or T4. If it is a T4, you have to stop it before 4 weeks. If it is T3, you have to stop it before 2 weeks. Even they are not tolerating the 2 or 3 weeks, then your recombinant TSH has the role. So they will give the recombinant TSH 2 injections intramuscular on consecutive days. After 24 hours, they will do the iodine 131 scan. So in that, so thyroid hormone withdrawal is must to raise the TSH above 30. You have to stop the T3. If the patient not tolerating hypothyroidism, T3, T4, and stop the T3 and T4 3 or 4 weeks before. If you are there not tolerating even the week time, then your role of recombinant TSH will come. And the stunning effect, as I told you, before doing the diagnostic scan, if the patient is intermediate and high risk, there is no role for the doing the diagnostic iodine 131 scan, then the therapy. You can directly go for the iodine therapy. And the role of steroids, if the patient is having bone mets or brain mets, if you are giving the iodine 131, it can produce the inflammatory tumor expansion. So it can produce the mass effect. To reduce that edema, other things, we will give the steroid with the iodine 131 treatment. It is a closed space lesions, particularly bone and the brain. And the preparation, any patient we are planning for iodine 131 treatment, we should advise them to reduce their iodine intake at least 1 week before the scan, and you should make them hydrate adequately because it will be taken orally. So your salivation will get affected and it should be excreted through the kidney, and your exposure will be there in the rectum. So your renal function, your colon function, and your hydration and oral thing should be maintained adequately in this patient. So this is about the iodine 131 treatment. And usually, this is all discussed. Usually when we are doing the diagnostic scan, it should be 1 to 5 microcuries. And the ablation, if you are taking, it is a low risk patient, it will be 30 microcuries. Intermediate and high risk, it will be 100 to 300 microcuries. And the replacement therapy, again the same thing. It is a TSH dependent tumor. So we should suppress suppressive dose of eltroxin should be given. So the ATA recommend would be, if it is a low risk patient, you should maintain the TSH to the level of 0.5 to 2 millunit per liter. If it is an intermediate risk patient, you have to maintain up to 0.1 to 0.5 million international unit per liter. If it is a high risk patient, it should be less than 0.1. So after surgery, this risk stratification is must. If you know that, then we will know which patient is iodine 131 treatment is needed, and which patient you should give the what is our target level of TSH we will know. And stage 4 tumors, the point which I want to stress is, if it is the operable tumor, it's better to operate and give the iodine 131 treatment. If it is an inoperable tumor and the tumor is not iodine 131 a bit, nowadays there is a role for the targeted therapies. That is the point. Initially they used to give radiotherapies and they will send it for chemo. We know that differentiated thyroid carcinomas are radio resistant and chemo resistant. It will not work better. It's only for palliation. But the recent trials and the FDA has approved targeted therapies for the thyroid cancer, particularly sorafenib, multiple tyrosine kinase inhibitor for the differentiated thyroid carcinoma, and vantetanib and cabozantinib for the medullary thyroid carcinoma. These are approved. So even the stage 4 diseases, the personalized medicine, the targeted therapies are there for these patients. And medullary thyroid carcinoma, as we discussed, if this patient will spread to the lymph node, so total thyroidectomy with an dissection is must for all the patients. And anaplastic carcinoma, if surgically resectable, it's better to go and remove the tumor. If it is a palliative, at least do the tracheostomy. And anaplastic carcinoma, if it is a palliation, you can give the radiotherapy and you can try with the chemotherapy. If it is a recurrent tumor, yes, the recurrent scan, you should do the regular follow-up with the patients. So one is the clinical examination. Second one will be your thyroglobulin. So thyroglobulin is elevated, then it will be considered as a biochemical recurrence. If you have the lesion with the things, it's correlating. They will divide into biochemical recurrence and structural recurrence. So clinically lesion is there and your thyroglobulin is elevated, then your management would be, if the lesion is resectable, resect that lesion, then do the iodine 131 scan. Any residual lesion or metastasis is there, treat with the iodine 131 treatment. If it is only biochemical recurrence, structurally not picked up by the iodine 131 scan, then do the PET CT, then act accordingly. So the regular follow-up would be do the thyroglobulin and the clinical examination. If any suspicious, then do the ultrasound. So the treatment of the recurrent cancer will be cell type, whether it is iodine 131 a bit or non a bit. Then what is the prior treatment they received and the site of recurrence. So this is the targeted therapy, as I told you previously. The PRAF inhibitor, dafranib, trametinib, and multiple tyrosine inhibitors, vantetanib and cabozantinib are approved in the FDA. So these are all the recent advances in the thyroid surgeries. So the take-home message, FNAC, most of the time it will diagnose the lesions. Only the follicular adenoma and carcinoma cannot be differentiated by FNAC. And thyroglobulin is a surrogate marker. You can use it for the differentiated thyroid carcinoma. And medullary carcinoma is diagnosed. You should know about the syndromic association and the familial predisposition. You should know before evaluating, during evaluation, you should know, have the caution about the stunning effect of our iodine. And all the rules, all the risk factors of thyroid carcinoma are not established except radiotherapy. It is the proven effect. All types are caused by radiotherapy except medullary, which has the familial predisposition. All type of cancers occur before 50 years except anaplastic. And all types of cancer are common in females except the anaplastic, where it will be common in a male. And all types are rarely associated with the genetic syndrome except medullary. Thank you, sir.
Lecture about the thyroid cancers. As you know that most of the participants are undergraduates, and we do keep cases of carcinoma thyroid in the exam. For undergraduates pertaining to the thyroid malignancies, we teach that conventionally any type of, whether it is a differentiated or undifferentiated, the treatment of choice is first to be the total thyroidectomy. Can you enlighten us the follow-up of the different cancers, sir? How to follow up following a thyroid surgery for follicular, for papillary, for medullary carcinoma?
The surgical treatment will be the same for both, sir. We have to do the total thyroidectomy. So the thing is, medullary thyroid carcinoma, it will be commonly metastasis to the lymph node. So we will not take it as a thing. We will do the prophylactic lymph node dissection in medullary thyroid carcinoma. Central compartment will be removed in the medullary thyroid carcinoma. Only thing is whether to do the lateral compartment. There is different theories and different documentations. Based on the calcitonin level, they will tell, sir, whether it is less than 50 or 50 to 100, what the level to do. But as a practical point, when we are doing the papillary thyroid cancer, if it is the intrathyroidal, other things, you, as I told you, it will not be needed. For the routinely central compartment is not needed. Because the hypoparathyroidisms, recurrent laryngeal nerve injuries are more common if you are doing the classical central compartment neck dissection. But considering the medullary, you have to address the neck. It should be addressed.
Sir, what about follicular?
And second thing, the medullary will not a radioiodine 131 avid diseases. So in that, there is no role for your iodine 131 scan, other things.
Sir, what about follicular carcinoma, sir? After total thyroidectomy, after how many weeks you want to do an iodine scan to know whether you have done it completely? If there is any residual after that, what is the plan, sir?
The problem, no, most of the time, as I told you, by doing FNAC, they will tell it is a follicular neoplasm.
Yes.
So it will be very difficult to tell. The patient immediately will ask us whether I developed cancer, sir, or not. And we know from our experience, most of the time when we operate, it will be a follicular adenoma. It's only 10 to 15% will be a carcinoma. So in that only, we have to see the ultrasound features. As I discussed, whether it is solid, vascularity, taller than wider, if these high risk features are there, then you will consider this as a malignant lesion. But better you have to explain to the patient, because no test is 100% sure to differentiate the adenoma from the carcinoma. By doing the, if you are submitting the tissues only, they can differentiate. So what is our approach would be, we will discuss the patient. See, this is your report. This can be a, most of the time it can be a benign, but malignant chance is there. If the patient is accepting, we will do the hemithyroidectomy for the follicular neoplasm lesion. And we will ask the pathologist to rush to give as early as possible the report, and we will get the report within 10 days. We will go and operate the total thyroidectomy. And the follicular lesion, as we know, the nodal mets are very rare in follicular lesions. So common thing would be, if you are intraoperatively, when we are, if the report came as follicular carcinoma and I am doing the completion thyroidectomy, that time whether to do the central compartment neck dissection or not will be determined by, as I told you, my tumor size. If it is in hemithyroidectomy specimen, If it is a pathologically T3, T4 tumor, then I have to address the central compartment. If it is an early tumor, we can inspect by separating the strap muscles, as we separated by doing the thyroidectomy, we can inspect the central compartment. Then the significant nodes are there. If I am having the frozen facility, then I can pick up the node, then I can send it for the frozen. Then they told it is positive, then I have to complete the neck. This is the practical, this is the theoretical approach. But most of the time, most of the centers will not have the frozen. So what I used to, in Jipper, we used to follow is, at least we will do the central compartment on the side of the lesions. If it is the right side lesion, we will take the right side central compartment nodes and send it, sir. But there is a definitive role for frozen is there, but thing is, in even that also pitfalls are there. So how to solve the follicular lesion is, we have to do the surgery. So whether to do the total thyroidectomy or hemithyroidectomy, we have to discuss with the patient. We have to involve in the treatment decision making. Then we have to decide, sir.
Sir, what about anaplastic carcinoma? Inoperable. You told that tracheostomy is a must. Is it routinely you do it, or is there any role for hysterectomy? Still, you are doing hysterectomy in anaplastic carcinoma, sir?
Sir, anaplastic carcinoma, you are better than me, sir. Because if we have your experience only, you have to tell us. Because the anaplastic, what we have seen, what from my 5 years, 6 years experience, what I have seen, it's a very aggressive, sir. Initially, we had one tumor before the COVID era. We had a tumor. It was a nodal mets initially. We thought of papillary other things. We did FNAC repeatedly by doing ultrasound guided. Also, we did. They told it is only cystic. They told it is non-malignant. Then we missed the patient. The patient came after 6 months with a florid lesion in the neck. We are surprised to see within 6 months it was compressing the trachea and enhancing the carotid. It's completely inoperable. So, and taking practically by doing hysterectomy, other things in a bulky tumor to go and find the trachea, it will be sometimes very difficult, sir. But if it is possible, the idea is again the management would be as much as possible we have to remove the tumor. So it's like a debulking surgery. But some tumors, if they present early, then if you do the total thyroidectomy, it will be better. In that also, we have seen some patients. The patient presented early. We did the total thyroidectomy and we suggested a radiotherapy. But the patient defaulted. That patient also within 6 months, she developed a recurrence in the lungs. So anaplastic, it will be, sometimes we can't win the tumor biology. We have to accept the God decision. So anaplastic thing would be, if it is a locally aggressive, as much as possible, you have to operate. Without compromising the quality of life, if you are able to resect the tumor, it's better go ahead and resect. And one more point, the problem will be, sometimes it will be difficult to differentiate whether it is anaplastic or lymphoma or de-differentiated variant of papillary thyroid carcinoma. And we know the anaplastic will be a big tumors. So very rarely, as an exam question, they used to ask where you can do the true cut biopsy in thyroid would be anaplastic.
Is there any?
So send it for true cut, they will tell you.
Is there any drug available recently?
Chemotherapy.
Chemotherapy.
Yeah, role of chemotherapy in thyroid cancer.
The chemotherapy, they tried so many agents, doxorubicin, tecarubicin, other things. They have not produced the expected results, sir. So as we know, the tumor is de-differentiated, rapidly multiplying tumors, then the chemotherapy responsiveness will be better. If you take into consideration, anaplastic can work better in that scenario. But now the era would be a targeted lesions. We are studying each tumor, what the mutations, other things, they are coming up with the new agents and it producing the significant results. When I was in thyroid, in JIPMER, we kept the papillary thyroid carcinoma with metastatic patient. It was very extensive meds, iodine 113, everything is exhausted. We put her on sorafenib. 3 or 4 years he maintains. So we have to accept the fact because it was not routine in our place, but targeted therapies are having some roles. So if you take surgery, in oncology, our medical oncology colleagues are replacing us in every field, breast, other things, lungs. So in thyroid also they are coming with the targeted therapies and it has some effect, particularly the medullary thyroid carcinoma, other things, it was all FDA approved. So they have some survival benefit.
Role of radiotherapy for local recurrence, radiotherapy without going for surgery.
So sorry, sir.
Radiotherapy.
Role of radiotherapy in recurrence, local recurrence after
The
surgery.
radiotherapy, the principles are very same, sir. If the tumor is, if it is a recurrent tumor, I can do a R0 resection whenever it's possible, do it. So whether it is a nodal recurrence, it is a thyroid bed recurrence, if it is even some tumors infiltrating the larynx, if I do the total thyroidectomy with the laryngectomy, some will be improved, go ahead for the surgery because the tumor biology. So differentiated tumors, if the tumor load is less, then your iodine 131 will be better, your results will be better. But most of the time, our people will not give the consent for the extensive surgeries. They will tell, I will not go for the iodine 131 treatment. I have to go to Chennai, other places. Then you treat it in the local places. That time they will choose the radiotherapy, sir. Particularly the iodine 131 non-avid diseases and inoperable diseases. These are the two areas where the targeted therapies and radiotherapies will come, sir. Not as a routine, sir. Not as a routine. Radiotherapies are not as a routine. Most of the time, initially they used to treat with the radiotherapy. The iodine 131 concept, very few restricted area was there. They will not have that iodine 131 concept. They will operate, they will irradiate. That patient also doing fine. But thing is, understanding the tumor biology, since it's a differentiated tumor, if you give the iodine 131 tumor, and we know that thyroid cancer has the good survival if you do the correct job. So we have to try correctly for the patients rather than what we are having, treating with them what we are having.
Sir, there is some question. Can you see that chat box, sir?
Yes, sir.
Yeah.
Question and answer.
131 scan.
I-131 scan says no meds. I suspect iodine unavid tumor. I asked for quick.
Iodine 131 scan says no meds. I suspect iodine unavid tumor. I asked for petty. How can it should be wrong? Sir, the question I clearly told you. See, thing is, sir, the patient, it is in the recurrent setting. What sir's question will be recurrent setting. If the patient having I'm doing the thyroglobulin. Thyroglobulin is elevated and the patient is having the lesion clinically, then no role for iodine 131 treatment. You resect the tumor, then go for the iodine 131 scan. If you are having the biochemical recurrence, biochemically thyroglobulin is elevated, then I am suspecting some recurrence. That time I am doing iodine 131 scan, it's not picking up any lesion, then your PET CT is the investigation of choice. I'm not saying I will not do. I'm telling that is the investigation of choice. The ideology is patient having the disease because thyroid is there, his thyroglobulin is elevated. That means definitely some thyroid tissues there in the body. But I'm doing 131 scan, it's not picked up the lesion. That means during the course of the time, differentiated tumor can become the undifferentiated tumor. So the undifferentiated tumor will not have the symptoms and it will not uptake the iodine 131. And we know the aerobic glycolysis is the mechanism where the tumor cells survive. So it needs glucose. So by giving the fructose by the PET scan, it will pick up the lesion. So the indication for PET scan is patient having biochemical recurrence, iodine 131 scan is not picking up. That means iodine 131 non-avid diseases, PET scan is indicated.
Is there any questions from student side? Any questions? Sir, thank you, sir.
It gives me immense pleasure.
Thanks for the opportunity, sir. So you are making the young surgeons to present in these scenarios and making us proud, sir. And thanks, Dean sir and HOD sir and Medical Superintendent sir. recognizing me and asking me to present. Hope next time I will present better and I will share my ideas, sir. Thank you, sir. It's a very interactive session. Thank you very much, sir. Thank you.
You have done a good job. You have covered everything and you have clarified certain doubts also. It's very nice. Your presentation was also very nice. You covered most of the thing. It was nice only, and we learned a lot of things from your presentation. We cleared a lot of doubts from your presentation regarding recurrent tumors and other things. Thank you.
It gives me immense pleasure to deliver the vote of thanks for this event to all the dignitaries who are here. First, I would like to thank our Honorable Chairman, Mr. J. Satish Kumar, sir, then Professor Dr. P. Shanmugam, sir, Dean, AMCH, the Medical Superintendent, Sir, Dr. N. Mohan, and Professor Dr. B. Usha, Professor in HOD Microbiology, and of course, the Chairperson, Professor B. Triganasundam, sir, HOD Department of General Surgery. Finally, I would like to thank our Chief Guest, Dr. Shanmugam Sundaram, MCH Surgical Oncologist, Assistant Professor, Branch Medical College, who honored this webinar with his knowledge about thyroid malignancies. And finally, a small thanks to Dr. Shankar Raman for actively participating in this webinar. Thank you, one and all.
Thank you, sir.
Thank you.
Thank you so much.
Thank you.